Hello, everyone. Our topic today will be about opioids and opiates in clinical practice. This will be part one out of two parts, and we're going to continue the presentation, after the first session here, the second part. So these are the objectives of the presentation. Opioids, in fact, actually opiates was used, 3,000 years BC by the Greeks. And Hippocrates actually described it. And it was used for different reasons, for sleep, for pain, for recreational purposes. Actually, the old Egyptians have also used opium or opiates. The difference between opiates and opioids is very important to understand. Opiates are the natural form of opioids, the ones that are extracted from the opium seed poppy, like an extract, this white extract that comes from the Papaver seminiferum, and basically it's composed of mainly morphine and codeine and other stuff, but this is not of our concern right now. So when I refer to the word opiates, I mean codeine and morphine. Now, there are drugs that were extracted from these two drugs, and these are called semi-synthetic opioids, such as hydrocodone, hydromorphone, oxycodone, oxymorphone. These have the same chemical formula, like morphine and codeine. And then we have another category, which is called the synthetic opioids. These are totally different chemicals than the parent opioids, which is the morphine, such as methadone, fentanyl. I mean, you can see from this, slide here, they're basically different chemistry. So what are the chemical classes of opioids? We have 5 classes. We have phenanthrines, we have the benzomorphins, phenylpyridines, diphenylheptanes, and phenylpropylamines. Each of these has specific features. So the first group, actually, these are the morphine-like drugs. And these medications resemble a morphine. The ones that have a 6-hydroxyl group, such as the codeine or the morphine, these have specific features, like, they can cause hallucinations, for example. They can cause itching. They can cause, different side effects that's related to this 6-hydroxyl, nausea, and so forth. So the companies, the drug companies, what they did, they removed the 6-hydroxyl group, which gave us another, similar chemical groups that doesn't have the same side effects like codeine and morphine. Benzomorphins are important group because they have an anti-diarrhea effects, such as loperamide and diphenoxylate. Pentazocine is an old drug. We used to use it in very old days, 30 years back. It's still around in the United States, but it's not commonly used. It's under the name of Tolwyn. Phenylpyridine, which are meperidine-like derivatives. Fentanyl, alfenta, sulfenta, all of these are meperidine-like derivatives. And thus makes meperidine actually is not similar to morphine. It's a different chemical group. Most physicians think that meperidine is the same like morphine. No, that's not true. Meperidine is a different chemical group. Then we have the diphenylheptanes, okay, such as methadone and propoxyphene. Propoxyphene is not produced anymore, okay? It was stopped. It was a weak opioid, had some arrhythmogenic side effects, so they basically stopped it from production. Methadone is well known to have NMD antagonist activity, and thus it's very useful in neuropathic pain and also in opioid use disorders. Then we're the last group here, which is the phenylpropylamines, which are also called the cyclohexanols. We have tramadol. I'm sure all of you guys are aware about tramadol, which is a weak opioid, and then its cousin tapentadol. Tramadol and tapentadol work by a dual mechanism of action. They have immune agonist activity, and they also inhibit the reuptake of the catecholamines. And thus, they have drug-to-drug interactions, especially with MAO inhibitors and other SSRIs and selective norepinephrine reuptake inhibitors, and even TCAs, tricyclic antidepressants. Mechanism of action of opioids. Opioids work through attaching to a 7-transmembrane G receptor complex. It activates the G protein, inhibits adenylate cyclase, decrease the cyclic AMP, reduce the intracellular calcium in the presynaptic junction, and then it increases the potassium efflux. This is the 7-transmembrane G protein receptor, and this is basically, inhibiting the adenylate cyclase, reducing the cyclic AMP, reducing the intracellular calcium, which will reduce the release of neurotransmitters. Now, it also helps with increased potassium efflux, which hyperpolarizes the membrane, and thus it blocks the pain impulse. Again, morphine inhibits the inward or the influx of calcium in the presynaptic area, and this inhibits the release of the neurotransmitters from the presynaptic junction here, while it actually enhances the potassium efflux, hyperpolarizing the postsynaptic membrane here. Okay, opioids work in the multimodal model here by two ways. If you look here at number 4, the modulation, right? It also it helps with the perception, and also, and this is not in this figure here, if you have a peripheral injury, it can help with the transduction. So opioid receptors usually are not in the periphery, okay, unless there is a tissue injury. When you have a tissue injury, you will have opioid receptors in the periphery. And this has an application because now I can use like morphine spray, for example, on the decubitus ulcer, for example, okay? And now opioids help with nociceptive pain, not much so with inflammatory pain, and also it helps with neuropathic pain, but to a lesser degree than nociceptive pain. So in general, opioids, they don't work very well on the neuropathic pain, but they do. So if I raise up the dose, it will help the neuropathic element. All right. Now, I want to say there are exceptions to this rule, like methadone, for example, because it has an NMD antagonist activity. It does help with neuropathic pain. Also, the cyclohexanols, tramadol and tapentadol, because they have a dual mechanism of action. They help with neuropathic pain. Levorphanol, also, it's a morphine-like drug. It does have an NMDA antagonist activity, and it does help with neuropathic pain. Okay, now this picture here shows the different categories of opioids here. So we have partial agonists uh, like buprenorphine. All right, remember this is a very important thing, guys. Okay, buprenorphine is the emerging opioid right now. Although, I mean, eventually it will come to our countries. I mean, we have, I think in Saudi Arabia, they have the patches on. But trust me, within the next 10 years, buprenorphine will be available in all forms and shapes. So this is a drug that you need to really study very well. Okay, and then you have the pure agonist, which all of them work on the mu agonist, mu receptors. We have from Japan, we have a selective kappa opioid agonist called nalfurafine, which is basically used for perioditis related to renal failure. That's the only pure kappa agonist. Nalbuphine, pentazocine, butorphanol used to be called Stadol. I mean, when I was a resident all time, like 30 years ago or whatever, we used to use butorphanol for labor analgesia. It's a great drug, for labor and delivery, and it's still used in some places. The places don't have epidurals. Anyway, antagonists. We have naloxone. These are pure antagonists. Naloxone and naltrexone. And then we have a group of drugs called the pamoras. You guys have to remember this. The peripherally acting mu opioid receptor antagonists, pamoras. These are pure antagonists, but they don't cross the blood-brain barrier, and thus they do not reverse the analgesia. Okay, quick question here. Which of the opioids listed below has the only partial mu agonist activity? It's buprenorphine. So what is the value of what I'm talking about? Well, we know that buprenorphine is used for opioid use disorder, and we use it also for pain. The nice thing about it, this one is actually um, uh, has a ceiling effect as far as the respiratory depression, but it does not have a ceiling effect as far as analgesia, and that's the key here, and that's why it's safer. The buprenorphine is safer than the other types of opioids. This is the opioid conversion, chart, and I'm not going to go through each individual drug, but I want to give you a general concept here. Always remember morphine as the godfather of all of these opioids. Actually, the WHO always, monitored the palliative care, services by the amount of the morphine or the morphine equivalents used, at end of life. So morphine is the godfather. So whenever you do a switch from one opioid to another, you have to change to the oral morphine first, and then from oral morphine to the other drug. I want to say something about this. All the drugs you can, classify them into three groups. Okay. First group is methadone. Okay, this is one group its own because it has a special conversion, formulas. All right. In fact, methadone, the higher the dose, it becomes a stronger drug because of the NMDA antagonist activity. Also, we have another category, the patches. And then you have the rest of the opioids. So I say we have three groups: methadone, patches, and others. Okay, remember this because the patches also conversion has special formulas. All right, opioid receptors. So we have five types of receptors: mu, delta, kappa, nociceptin, or sometimes we call it the orphan receptor, the nociceptin, and zeta. Nociceptin and zeta receptors, there are a lot of research upon them and debates, and so I'm not going to go through them. But possibly tolerance is related to the nociceptin, and zeta is related to the regulation of cancer cell proliferation. Okay, mu is basically the most important. All right, that's the one responsible for euphoria, supraspinal analgesia, meiosis, physical dependence, respiratory depression, urine retention, perioritis, all the side effects, nausea, ileus. The kappa is also important, and we're gonna talk about it in a second. Kappa is related to spinal analgesia, sedation, and dysphoria. Now, if you have a kappa agonist activity, like a pure kappa, it can be helpful in patients with like itching. But if you have an anti-kappa, okay, and we're going to talk about it later on, this will prevent opioid-induced hyperalgesia. So this is a pretty new information. I'm throwing this, and we're going to talk about it later. Okay, so where are the opioid receptors in the brain? Everywhere. I mean, it could be everywhere in the brain, in the dorsal horn, in the Pribotzinger complex, the complex that's responsible for inspiration and breathing, a nucleus solitarius, which is basically the nucleus, vagal nucleus, the sensory vagal nucleus. And then the limbic system. Remember, opioids work on your emotional aspect of your pain, which is present in your limbic system. So the only part that's not, there are no opioid receptors is the cerebellum. Remember also, opioids have peripheral receptors when you have a tissue injury. Without a tissue injury, there are no peripheral opioid receptors. This is very important, guys. I mean, there have been studies where they had patients with osteoarthritis. They injected morphine inside the knees, okay, for pain control, because there's a tissue injury. The cubitus ulcers, you can spray them with some morphine, or you can put some methadone on. Okay, context sensitive heart time. This is a term important for certain drugs in anesthesia. Okay, and probably it will be used in palliative care in the future. So it's the time required for the plasma drug to decline by 50% after terminating the infusion. Remifentanil is a relatively context insensitive, while fentanyl is an example of a drug that has a significant context sensitive changes. So the context sensitive half-life for remifentanil is 4 minutes after 4 hours. This is very important because it has a lot of clinical implications to all of us. Anesthesia, palliative pain, remifentanil, look at it. It's down below there. Fentanyl. So let's say I'm working in a palliative care unit. I'm running a fentanyl infusion. The fentanyl is accumulating in your body. I mean, if you keep giving it for days and days, you're just accumulating fentanyl. Okay? Don't think that if once you stop the fentanyl infusion, everything will go away. It will take time to, get out of your system. So that's why remifentanil is used for short cases, for what we call TIVA, total intravenous anesthesia cases and stuff like that. But there's only one report about remifentanil in palliative care. I guess there will be more. in the future. Opioid metabolism is through the liver, and the excretion is through the kidney. The liver has two phases, phase one and phase two. Phase one is the oxidation, uh, you know, oxidation, reduction, hydrolysis, but mainly oxidation. And phase two is conjugation. These are the oxidative enzymes P450. The most common abundant one is the 3A4. And then this is followed by the 2D6. And then lots of others. You don't have to memorize all of them, but just for the sake of completion. Uh, I call them these. I call them the good, bad, and the ugly. So we'll start with the good, which is the conjugation. So the drugs that are conjugated, they don't have a lot of drug-to-drug interactions, such as morphine and hydromorphone and others. While the 3A4 medications are metabolized into inactive metabolites, such as fentanyl, methadone, and all that. I call them the bad ones. Okay. Now, with the bad ones, if you add a drug like macrolides, for example, like erythromycin, if you add erythromycin to fentanyl, I mean, this will inhibit the metabolism of fentanyl. This will increase the fentanyl concentration, and it can lead to respiratory depression. I've seen guys, at least 3 cases like this in my clinical practice. All right. Patients, they go to the primary care, they're on the patch. You give them fun, the primary is you can go into respiratory depression. Even grapefruit, I mean, grapefruit can cause the same problem, guys. All right. So this is important. I just wanted to let you know it's very important. Um, the ugly is the 2D6. And in this situation, the drug is metabolized to metabolize. So let us say you give an SSRI to a patient with, SSRI to a patient getting oxycodone, for example. This will change it. So this will inhibit it from the active metabolite. So it will reduce the efficacy of the drug. Okay, so it's opposite to the 3A4 system. All right. So I'm going to give you a quick question here. Which class of medications inhibit and induces the clearance of methadone and fentanyl, respectively, via the 3A4 isoform of the CYP450? So the answer is macrolides and phenytoin. Macrolides, like erythromycin, and phenytoin. The phenytoin induces, the macrolides inhibits. Again, I get back to the picture here. So fentanyl and methadone. You see here the inhibitors, macrolides, inducers are phenobarb and phenytoin and carbamazepine. So patients that are taking carbamazepine or tegretol, probably this will reduce the efficacy of the fentanyl big time, and they will need a much higher dose than a normal person. Why? Because it activates the enzyme that change them to inactive metabolites. I hope this is very clear. You have to understand the concept, and once you do so, everything becomes pretty simple. All right. Now, these enzymes are classified into 4 groups: poor, intermediate, extensive, and ultra rapid. And this is done through something called genetic testing. I used to do the genetic testing like back in the United States, maybe more than 15 years ago. I mean, you send just a little specimen from the saliva in a certain tube, special tube, and the company runs all these tests for you. Okay. Now, extensive is the normal variant. All right. So, what is the importance of this? This will be shown in this case, for example. A 45 Ethiopian lady is nearing hospital discharge after total thyroidectomy. After transitioning from IV hydromorphone to oral codeine, she reports significant drowsiness followed by inadequate pain control. Okay, which of the following medications is the most appropriate alternative in analgesic? So the answer is morphine. Okay, so why is that? Because codeine again is metabolized, as you know, by the 2D6, and the 2D6, in fact, is in actually in Ethiopians and in even Saudi Arabians, there are at least 10 to 20% of the population that have a hyperactive form. All right. So that's why she got drowsy, because codeine is changed in your body to a stronger drug, which is basically morphine. So anyway, morphine is metabolized by conjugation. So it's the good, right? It's there's no drug to drug interaction. Opioid metabolites of morphine, unfortunately, can accumulate in renal failure patients, okay, to basically M3G and M6G. M3G is excitatory, M6G is super analgesic, much stronger than the parent drug. And that's why morphine ends up being, mixed delirium. Patient, you see him comatose and on the same time having myoclonus. I see this all the time in the oncology department because they start morphine and then they start their chemotherapy. Patient goes into dehydration, toxic effects of the chemo. The morphine, they get intoxicated with morphine and they end in the ER with, mixed delirium. Hydromorphone is only metabolized to H3G. Non-pain uses for opioids, dyspnea, diarrhea, and cough. So we use opioids for intractable dyspnea after treating the causative factor of dyspnea. It's not a first choice. This is like the peak of the pyramid here. All right, and the doses that you need for dyspnea is much smaller than pain. And also, there's no evidence of opioid nebulizer use in relief of breathlessness. They tried fentanyl nebulizer, okay, and it did not help dyspnea. So this is a question in the exam here. And they work through the pre-Butzinger complex in the middle. This is the pre-Butzinger complex here. Okay, and this is the nucleus solitarius for cough. All right. That's the vagal nucleus, sensory vagal nucleus. These are the doses we use for, for dyspnea, much smaller than pain, as you can see. For diarrhea, we have an opioid called loperamide. All right, that's the first choice. Loperamide is a great drug for diarrhea, and you should learn about it because you don't want to overdose the patient with loperamide. There are case reports where loperamide doesn't cross the blood-brain barrier normally, but if you overdose to get some high from it, all right, you can get into torsade de pointe and it can kill you basically. And there are case reports of patients overdose themselves with loperamide. So the maximum dose is basically 16 milligram per day. Other drugs for diarrhea, tincture of opium and Lomotil, which is diphenoxylate and atropine. All right. These are the most famous drugs for diarrhea. Loperamide is the one over the counter. diphenoxylate, and the opium 1%. It's a mix between codeine and morphine. These are, classified drugs. And the reason they work on diarrhea because we have mu receptors in your GI. How about cough? Well, the most famous one for cough is dextromethorphan, followed by codeine, right? But in fact, morphine works pretty good, and also hydrocodone works very good for cough. And again, this is for intractable coughs. This is a cough drugs in the 19th century. They used actually, look at this, they used, cannabis, chloroform, and morphine. So I guess they had a great time in the 19th century. All right, these are the drugs we use nowadays for, cough, for intractable cough. Dextromethorphan has an NMD antagonist activity, and they try to use it in pain, but you really need a very high dose to, benefit, to get the benefit out of it. Opioid use disorders. Uh, it's a widespread disease. Opioid users in the United States, 92 million. High opioid utilizers, 15 million. And we have 2 million addicts in the United States. It has a criteria in the DSM-5, and basically it's a problematic pattern of opioid use leading to clinically significant impairment or distress as manifested by at least two of the following, occurring within a 12-month period. Opioids are often taken in larger amounts. There is a persistent desire or unsuccessful efforts to cut down. Also, a great deal of time is spent in activities necessary to obtain the opioids, and then craving or a strong desire or urge to use opioids. And there are other criteria. I would recommend that you read them, on your own time here. We use something called Opioid Risk Tool, ORT, to evaluate the risk of opioid abuse. This is very important. It's composed of five, categories here. You can fill it up. Patient can fill it up. It doesn't matter. Patients that have low risk is 0 to 3, moderate risk 4 to 7, and high risk is more than 8. This was basic tool in our palliative care clinic before the patient is seen. We used to fill up this opioid risk tool. Okay, another thing that I want to talk about is opiate withdrawal timeline, because patients that have opioid use disorder can get to opiate withdrawal symptoms if they stop the drug abruptly. And usually the symptoms peak after 72 hours. All right. So this is important, guys. But longer acting drugs, it takes longer time, at least 30 hours to start to have the symptoms, while 6 to 12 hours in shorter acting opioids. Also, there is a clinical opioid withdrawal scale that we use in USA for, picking up the withdrawal symptoms and signs. The importance of these cows is called cows, okay, is to pick up the appropriate time to start the addiction medication such as the buprenorphine, because patient got to have a moderate opiate withdrawal before you start the buprenorphine. That's the most important part of it. So here, before prescribing Suboxone, which is a buprenorphine slash naloxone, for patient withdrawing from opiates, we administer this COWS scale, at what point here? It has to be moderate withdrawal, which is between 13 and 24. Look at down below here. Moderate is 13 to 24. Okay. Otherwise, you will have a manifest withdrawal symptoms. Opioids, acute versus chronic, uh, generally don't give more than 7 days upon discharge here. And I want to say, acute postoperative pain can lead to postoperative increased postoperative opioid requirements. All right. Um, the other thing is, I want to say that there is no role of opioids in the long term for non-cancer pain. Okay. Um, Again, I always emphasize on what's opioid tolerant versus opioid naive. Um, Urine drug testing, we'll keep it for the